Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz. Hematology, like cardiology, is very interesting in terms of there are points that we need to logically understand. There are lists, long-standing lists that we need to remember. Ultimately, there are some 400 to 500 points that we need to master in the hematology. With that preamble, let's make the great beginning. Good to see 3 online classmates now. Yesterday we were discussing about thalassemia, Citroblastic Anemia, etc., etc. We finished Citroblastic Anemia? Okay. Yeah, we discussed this. Yeah. So, anemia of chronic disease. Typically, whenever there is any chronic inflammation, like rheumatoid arthritis, chronic osteomyelitis, any long-standing inflammation, tuberculosis in India, right? So, what will happen during that time? Whenever there is chronic inflammation, the release of the iron become blocked in the gut. Iron uptake is decreased. And because of that, there is a development of anemia. And also, there is iron is captured as ferroportin in the erythrocytes. So there is an internalization and degradation of this ferroportin in the enterocytes and macrophages, not RBCs, enterocytes. Because of this degradation of ferroportin, iron absorption get affected, and that lead to development of anemia. So that is the main thing, commonly asked question. How do you differentiate anemia of chronic disease versus iron deficiency anemia? Main difference is ferritin. In case of iron deficiency, ferritin is increased. Whereas in the case of the anemia of chronic disease, ferritin is an acute phase reactant that you see in chronic inflammation, constantly elevated. So that is the reason the ferritin is either normal to decreased, normal to increased in case of anemia of chronic disease, which is the differentiator is what you need to remember. Then Erythrocyte protoporphyrin. Protoporphyrin become porphyrin only if iron is added to that. In iron deficiency, because of the iron deficiency, protoporphyrin elevates because there is no iron available to bind with protoporphyrin. Even in anemia of chronic disease also, the free erythrocyte protoporphyrin is increased just like in iron deficiency. That's the reason always closest to differential diagnosis in patients of rheumatoid arthritis who come to your clinic is whether this is iron deficiency anemia alone or is it anemia of chronic disease. If the ferritin is high, iron is low, then think of anemia of chronic disease. Ferritin is low, iron is also low, then think of iron deficiency. In fact, in iron deficiency anemia, one of the earliest things in laboratory to become abnormal is ferritin when there is iron deficiency anemia. Low ferritin is one of the early indicators of iron deficiency is what you have to emphatically remember for the tomorrow's exam. Patients who have classical PNH. So what is meant by PNH? Paroxysmal nocturnal hemoglobinuria. Means paroxysmal. It's not continuous. It only happens in episodes. Nocturnal, aaj ki raat se, nocturnal. Hemoglobinuria, finding the hemoglobin released from the broken RBC, it will appear in the urine. Hemoglobinuria. Now the question comes. What is the problem in paroxysmal nocturnal hemoglobinuria? Why hemolysis is happening? And why it is only happening in paroxysms? And why only in the night it is happening? Let us talk about it, right? Basically, there is something called decay accelerating factor, DAF. This DAF will be there on the RBC membrane. This DAF prevents the hemolysis of the RBC done by the complement. Complement is like the villain, right? Complement want to sabotage the RBC and break it down. Decay accelerating factor prevents it. So the name is decay acceleration does not mean it accelerates the decay. Name is decay acceleration factor, but it protects the RBC from the attack of complement, and complement mediated lysis is what you have to basically remember. So typically in these people who have PNH, congenitally they have a deficiency, genetic deficiency of this decay accelerating factor. That's the reason when the RBC is floating in the blood, it is like a naive girl going, and the villain comes and jumps on her. Who is the regular hero? Decay accelerating factor. But he is not available, right? So like Sita is going, Ravan comes. Ram is missing. That is the story of decay accelerating factor. Now, why only night? The complement mediated lysis of the RBCs occur if the pH of the blood is more acidic. So in the night, what happens? We sleep. When we sleep, what will happen? Our respiratory rate will come down. Normally, what is the function of ventilation and respiration? The carbon dioxide produced, it will ventilate out. If the respiratory rate comes down, the carbon dioxide does not ventilate out. So high carbon dioxide in the plasma that converts into carbonic acid that releases the H plus ion. That's the reason carbon dioxide is called volatile acid. So whenever you are sleeping, when your respiratory rate is down, and that lead to hypercapnia, that lead to carbonic acid, and that lead to respiratory acidosis. Acidosis will cause pH to come down, and that is the very attractive environment for our villain complement to go and cause the lysis. By the time it is morning, the guy woke up and then he is breathing very well, right? And all the carbon dioxide gone out, Acidosis resolved, hemoglobinuria also resolved. So that is a classical paroxysmal nocturnal hemoglobinuria. All right. So what is happening in this? There is a hemolysis happening. Where is it happening? Hemolysis is typically happening inside the blood vessel. That's called intravascular hemolysis. What is meant by extravascular? When the blood enters the spleen, outside the blood vessel, it enters the spleen. There the hemolysis is called extravascular. In the spleen, in the all reticuloendothelial system, that is called, or in the bone marrow, anything is all extravascular. So in PNH, typically you find hemolytic anemia, which is intravascular. And because of that, what will happen? Obviously, bone marrow is producing RBCs normally, but they are broken down when it is passing through the blood vessel. So that lead to a kind of a decreased oxygen delivery if anemia is there. That stimulates erythropoietin production. That will go and tell bone marrow to produce more. And bone marrow produces more RBCs. It produces, instead of full mature RBCs, it will produce reticulocytes. Always remember, any patient, if he has anemia, comes to you with a complete blood picture. There you look for the reti count. If the reticulocyte count is high, more than 7%, more than 6%, brisk reticulocytosis, that means iron is available, RBCs are produced, bone marrow is trying to compensate. That means there is somewhere hemolysis happening. So anemia with brisk reticulocytosis is equal to hemolytic anemia. Anemia with a normal reticulocyte count is equal to iron deficiency anemia. Anemia with low reti count is equal to aplastic anemia. That means bone marrow failed, is what you need to remember. All right. Similarly, a patient of iron deficiency anemia, once you start giving him iron therapy, then also the bone marrow now got a stimulation. In iron deficiency, iron is not there. Now iron you are supplementing. So the bone marrow will quickly compensate anemia by producing reticulocytosis. So the initial response that comes, if you want to know whether patient is responsive to your iron therapy, look for the reti count. If the reticulocytosis is happening typically within 72 to 96 hours, then that means patient is responding. All right. So elevated reti count, elevated LDH, and is a classical feature of paroxysmal nocturnal hemoglobinuria. Now, this decay accelerating factor deficiency is there, no, doctor? So this decay accelerating factor deficiency not only involves RBCs, it also involves other cell lines. You have platelets, you have neutrophils, etc. So that is the reason the problem is not just with erythroid series. Even the problem is with myeloid series, platelets, production, megakaryocyte series also. That's the reason you find thrombocytopenias in PNH patients. And also the patients who have leukopenias. If you do the bone marrow, they will have hypocellularity, bone marrow biopsy in paroxysmal nocturnal hemoglobinuria. And classical in paroxysmal nocturnal hemoglobinuria, if you take a complete blood picture, the granulocytes are there, no? You find large PNH granulocyte population. That is more than 30% will be the WBC count. Platelet count will be low, but WBC count, granulocytes especially, become more than 30% is a very classical thing. So summarize, doctor, what do you have in classical PNH? Cytopenias, normo to hypocellular marrow, elevated reti count, markedly elevated LDH, and also large PNH granulocyte population more than 30%. So please remember, this classical combination is what you need to remember. There is another type of PNH called hypoplastic PNH. This has got moderate to severe cytopenias, hypocellular bone marrow, that is less than 25% of the cells only are there in the bone marrow, right? And in these people, reti count instead of being high, what will happen the moment PNH patients develop a hypocellular marrow? Reticulocytes are produced by bone marrow, no? So the bone marrow itself shows hypocellularity, a plastic nature. Then your reti count will become decreased. So that is the reason a PNH patient, if his reti count is high means it's called classical PNH. But a PNH patient who is showing low reticulocyte count means it is hypoplastic PNH is what you need to remember. Even in them, there is an elevated LDH and relatively small PNH granulocyte population, less than 20%. So this is what you find in hypoplastic PNH. So two types of PNH: complement mediated lysis, decay accelerating factor. Little Puvu, Pushpam, Prema will finish the love letter, right? So that's what you need to know about the PNH. All right. Now comes the next important topic for the examiner. Hypoproliferative anemias. Hypoproliferative is a voice broadcast fine online? Huh? Okay. Hypoproliferative anemias. What do you mean by hypoproliferative? It means the bone marrow is not producing adequately. That is leading to anemias. Hypoproliferative anemias are divided into three types. Those who show microcytic picture, normocytic picture, macrocytic. Micro, normo, macro, based on what? Mean corpuscular volume. Less than 80 is microcytic, 80 to 95 is normocytic, more than 95 is macrocytic. Right? Now, one of the favorite questions of the examiner is, first of all, how do you know it is a hypoproliferative anemia? Any anemia, patient has anemia with a low reti count, is hypoproliferative anemia. So where do you find hypoproliferative anemia with a microcytic picture? Iron deficiency, classical example. Anemia of chronic disease, thalassemia, citroblastic anemia, lead poisoning. In all these, reti count will be low. And there is a microcytic anemia. And where do you find normocytic but reti count low? Renal failure, anemia of chronic disease, hypothyroidism, aplastic anemia, and acute blood loss. In all this, normocytic it will be, but low reti count and hyperproliferative anemia. Where do you find macrocytic anemia with a low reti count? Vitamin B12, folate deficiency, hypothyroidism, myelodysplasia, and alcoholic liver disease. So you need to remember, have you heard the word megaloblastic anemia? Right? So megaloblastic is a type of a macrocytic anemia. But megaloblastic macrocytic anemia, you find it in vitamin B12 deficiency and folate. And the remaining three are there, no doctor? Hypothyroidism, myelodysplasia, alcoholic liver disease. These are the examples of non-megaloblastic macrocytic hypoproliferative anemia with a low reti count. Right? So, sure short MCQ in the tomorrow's NEETPG. Right? So, I will push the notes in such a way that it's like an intrathecal methotrexate injection, straight to the crosses the meninges. No humbug. Most essential points. In this, some need to be remembered logically, some need to be mugged, some can be ignored in subjects like SPM. Some bridging points are there. Medicine is not like that. Almost every point is a hot cake, right? Now, doctor, low reti count, normocytic anemia. Already we discussed. Red cell aplasia, Fanconi's anemia, any marrow some of the cancers, they can go and infiltrate the marrow. Whenever the anemia occur because of the cancer infiltrating marrow is called myelophysic anemia is the name given whenever there is any bone marrow infiltrative conditions by the cancers mets to the bone marrow. So marrow damage, marrow infiltration, marrow fibrosis, right? Then malignancy, which can infiltrate. Any decreased stimulation like in kidney disease. Why chronic renal failure patients have anemia? Because they can't produce erythropoietin, no erythropoietin. And chronic inflammation, they're all hypoproliferative anemias, which are normocytic. In fact, chronic inflammation can cause both types. Normocytic and also microcytic. Then macrocytic, already we discussed. Vitamin B12 deficiency, folate deficiency, orotic aciduria. So there is one more important thing called orotic aciduria. Orotic acid is typically we see it in pyrimidine metabolism, right? Orotic acid. I'll come to that. Then Lesch-Nyhan syndrome. Have you heard of this? No? Oh my God. No problem. Lesch-Nyhan syndrome is partial, next word, don't be afraid. HGPRT deficiency. Hypoxanthine guanine phosphoribosyl transferase. Pentose phosphate pathway you heard? PPP. Puvuku panikirane puvu. Pujaku panikirane puvu. PPP. Pentose phosphate pathway. It's also called HMP shunt. Hexose monophosphate shunt. There, one of the enzymes you have HG, hypoxanthine, guanine, phosphoribosyl transferase, right? And purine metabolism. All this we will discuss in biochemistry. Don't worry. So, partial deficiency of HGPRT patients are called Lesch-Nyhan syndrome. Even they will show a hypoproliferative anemia. Yeah. Then liver disease. Alcohol, hypothyroidism, refractory anemia, thiamine deficiency anemia. If you don't, thiamine deficiency also lead to anemia. If you don't treat it, they all can lead to hypoproliferative anemias, which are macrocytic. So after going home, these you tick mark our Kausalya, Supraja, Rama program, right? Until exam. Second time, third time, fourth time, it become easy. It becomes playful. The one who masters medicine, surgery, gynops, orthopediatrics, that is all entrance. Chiller, anatomy, physiology, biochemistry, kuch bhi nahi hai. Padho, nahi padho, aayega marks. Right? Real stamina means medicine, surgery, gynops, orthopediatrics, pharmacology. Right? Pharmacology. So that will suck the blood. 6 subjects, right? Remaining all working knowledge. Anat, physio, biochem, micro, then pathology anyway is general medicine. Forensic, hardly, not more than 1 day you should not study. That's not good for health, right? Ante. That's the only thing. MBBS also it is like that. MD also it is like that. Maximum 10 hours. Too much. 10 hours of your young life sponsored to that. Not more than 1,000 points list. Out of them, 200, 300 points, you need to do the revision. Right? So, high reti count. Now, next is anemia with high reti count. That means bone marrow is overworking to compensate anemia. Typically happens whenever you have hemolysis. Any hemolysis, if it is there, RBCs are broken means the mother will be overworking to save the RBC population. It will be producing more and more. So, transfusion reaction, snake bite, anything that lead to hemolysis, thermal burns, mechanical heart valves. When a mechanical heart valve is there, RBC is passing, it will be broken. And paroxysmal nocturnal hemoglobinuria or paroxysmal cold hemoglobinuria. Paroxysmal cold hemoglobinuria. That is different from paroxysmal nocturnal hemoglobinuria. Paroxysmal cold hemoglobinuria is, there are some antibodies called cold agglutinins. They will go and attack the RBCs. It is an autoimmune type of a hemolysis, PCH. But these are all the causes where bone marrow will overproduce reticount, and reticount will be high. All right? So always remember, so don't forget this fundamental principle. Doctor, a lot of times whenever I meet the residents, I keep telling, first anemia means look for reticount. Reticount is high means hyperproliferative. Hyperproliferative, look for any source of hemolysis, right? So now high reticount can occur in whenever there is an extravascular or intravascular hemolysis. So what are the various conditions where extravascular, that means spleen is the graveyard, which is slaughtering the RBCs. Where are they? Hemoglobinopathies like your thalassemias, membrane defects like your spherocytosis, elliptocytosis, any autoimmune hemolysis, G6PD deficiency, so that antioxidants which protect the RBC from oxidant injury are missing, G6PD deficiency. Similarly, disseminated intravascular coagulation, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. These are the three conditions you need to remember which lead to development of hemolysis. DIC, TTP, HUS. What is meant by TTP? Thrombotic thrombocytopenic purpura. Purpura occurs because of the thrombocytopenia, everyone knows. What is the difference between purpura and petechiae? Big size is purpura. Small bleeding spots are called petechiae. Size is the differentiator. Once more, purpura typically you see in the elderly people, when they fall down, they will get a collection of blood under the skin, no? Elderly people, right? So they have purpura, larger collection of the blood under the skin. Purpura can be of two types. You can palpate them, palpable purpura, and the ones you cannot palpate them. The ones you see in thrombocytopenia are impalpable purpura. You are able to palpate them. Palpable purpura are the sign of vasculitis. So vasculitis lead to palpable purpura. Thrombocytopenia lead to impalpable purpura. That's the point you need to remember. So this TTP, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, hemolysis is there, uremia, renal failure is there, it's a syndrome. And disseminated intravascular coagulation. These three are called microangiopathic hemolytic anemias, MAHA. Microangiopathic hemolytic anemias. Why are they called like that? We will discuss in a great detail about the TTP later. Okay? We'll come through the blood vessel. When the RBC is passing, this thrombi which are formed, through them it need to squeeze and it get broken. So microangiopathic, because it's a small vessel, hemolytic anemias is what you have to remember. All right. So summarize, doctor. Hyperproliferative anemia, which is extravascular hemolysis, is hemoglobinopathies, membrane defects like spherocytosis, elliptocytosis, autoimmune hemolysis, G6PD deficiency, and all the microangiopathic hemolysis like DIC, TTP, HUS. Then comes eclampsia. In all these conditions is what you need to remember. Now comes the red cell distribution bit. Let us have a few comments about it. I'm so happy to see 4 online classmates. Very good, doctor. Yesterday only we discussed, no? Why do you get RDs? What is RDW? Whenever anisocytosis is there, one big cell, one small cell, you are plotting the size on the x-axis, number on the y-axis. If everything is of uniformly produced, then RDW will be normal. But if you have small on one side and very large on the other side, then the width of this graph will increase, which is called elevated RDW. Always an elevated RDW is a sign of anisocytosis is what you need to remember. And where do you see anisocytosis? When will our bone marrow will start producing small size? There is a very famous song, no? जिसका बीबी मोटी उसका भी बड़ा नाम है, जिसकी बीबी लंबी उसका भी बड़ा नाम है. तो मोटी मोटी छोटी छोटी, तो like that, the bone marrow, like Amitabh Bachchan will be singing, tall ho, mota ho, dubla ho, chota ho, kuch bhi ho, RBC ko produce karo whenever there is iron deficiency anemia. So iron deficiency anemia is associated with anisocytosis that lead to increased RDW is what you need to remember. So what is the normal RDW? Normal RDW is less than 14.5%, but tomorrow fact. And anisocytosis, you can see, that is anisocytosis. Then one is size. Second thing is what in our life? Shape. Right? One is size, other is shape. Both the things are very important when you go to shadi.com. So, poikilocytosis means one is like potlakaya, another is like gumadikaya. You have to accept. It's not that all boys like slim girls. Some boys like curvaceous girls. Some girls like chubby fat black guy. Someone want like Amir Khan. So different priorities are there, right? So if all priorities are taken care by the bone marrow, that is called poikilocytosis is what you need to remember. Once more, poikilocytosis, anisocytosis, they are the things that are seen in iron deficiency. Whereas thalassemia, every RBC is of the same size and shape. Then the main problem is in the hemoglobin production, which is common to all cells. So that is the important differentiator. How do you differentiate whether the given microcytic hypochromic anemia is thalassemia or iron deficiency? Iron deficiency lead to anisocytosis, increased RDW, poikilocytosis, but no anisocytosis, no poikilocytosis, normal RDW is equal to thalassemia is what you need to remember. Good to see Swapan Singh and 5 more who are all online. Very good, doctor. Now, so somebody was asking, today NEETPG results came. What are you going to do? I said, if you go to a graveyard and you ask the guy who burns in the graveyard, no, what are you going to do today? Death is over, next death will come, next death will come, next death will come. Past 25 years, we are seeing death and birth routinely. For obstetrician, is there any happy birthday? No, every day is a happy birthday for a obstetrician. So my job is that of an obstetrician to produce the people who get the ranks and those who lose the ranks. Honestly speaking, they get it by their own strength and they need to apply the mind in the exam hall. My job is only to push, 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 right? That's the only thing. So that's the reason, not a lot of excitement, but it's okay. So once more, I want to tell you, doctor, we get the seat not by sympathy, not by some miraculous power of vibhuti given by a Baba like teacher, right? Nowadays, all Babas have become sex scandal Babas and Swamijis, right? So that is not how you get. You get it not by running for some coaching or some thing. You need to know what are the 50,000 points and do a revision. At least dedicate 600 hours of your time, at least one shot. Once you finish this 50,000 points, at least one time, you don't do revision also, you will get a very good rank. But how do you finish this 50,000 is the question. Some will say, oh, go and watch videos. That is drowsy job. Some will say, read the book, drowsy job. You need someone who will sit with you and discuss, right? So take the 2,500 pages notes that we will give you. Sit along, bookmark the points that you are going to forget. Do the revision. Those which are logically need to be remembered, try to remember them logically. All right. So why RDW increases somewhere, why RDW comes down somewhere means, first of all, you should know what is RDW and why it alters and what is its importance, right? So now, doctor, increase, Suresh. So increased RDW tends to be 100% sensitive feature of iron deficiency. So it is not specific. But if you are thinking iron deficiency and you have to get the RDW done, because in very early stages of iron deficiency, when nothing else is abnormal, you will start finding the anisocytosis, and that causes an increase in RDW. That's the importance of RDW. So thalassemia is a normal RDW. Increased RDW is a feature of IDA, iron deficiency. Tomorrow, sure, short NEETPG point. The next is free erythrocyte protoporphyrin. So if you don't have iron, free erythrocyte protoporphyrin. Yesterday we discussed glycine plus oxygenyl choline. CoA is ALA gives parfobilinogen hydroxy methylbilane to uroporphyrinogen 3 to porphyrinogen 3 to protoporphyrinogen 9 to protoporphyrin to heme. So here iron should be incorporated. Iron should be incorporated is what you need to basically remember. So free erythrocytic protoporphyrin typically is normal in thalassemia, but in iron deficiency, Citroblastic anemia, anemia of chronic disease, in all that, free erythrocyte protoporphyrin levels are typically high, because iron is not available for that to be incorporated into protoporphyrin. All right. So you have two types of laddus. A laddu with kismis inside it, laddu without kismis. Iron is like kismis. So it's a Tirupati laddu. If it is normal RBC with a normal heme with iron incorporated. If it is not there, it become a kismisless laddu, which is typical of high protoporphyrin, is what you need to remember. So hypochromic microcytic anemias, where you find decreased iron with the increased TIBC. Where do you see? Total iron binding capacity. Total iron binding capacity. In iron deficiency, you find decreased iron with the increased TIBC. Okay? Suresh, Please ask Manu to call Abhishek. He's calling me. So then, hypochromic microcytic anemia with a decreased serum iron and a decreased TIBC is the feature of anemia of chronic disease. Now comes sir, a TIBC क्या है? भैया total iron binding capacity क्या है? Why it is increased in iron deficiency? Why it is decreased in anemia of chronic disease? उसके बारे में हम चर्चा करेंगे. So we'll come to that. One word about hemochromatosis. Hemochromatosis is a condition where serum iron is high and ferritin is high, and saturation of the transferrin with the iron is also very high. Just opposite to iron deficiency. In iron deficiency, serum iron is low, serum ferritin is low, and the transferrin saturation with iron is also low. Transferrin saturation high, serum iron high, ferritin high is equal to hemochromatosis is what you need to remember. All right. So what's happening in hemochromatosis? Basically, you have something called hepcidin, ferroportin. Just before we said no ferroportin in the intestine, right, for the gut release of iron. So there is an uncontrolled release of the iron from the macrophages and duodenal enterocytes. Both of them release too much of iron, and typically that leads to the iron overloading is what you need to remember. That is what happens in hemochromatosis, and that is called what? Primary hemochromatosis. That means there is a secondary hemochromatosis also. Suppose you are giving to a thalassemia patient with anemia, repeated blood transfusions. You are loading iron to him. That is what? Secondary hemochromatosis. Primary means there is a genetic defect in them. There is one HFE gene. Right? So, in HFE gene is abnormal, mutated. Then there is an uncontrolled release of iron from the enterocytes and macrophages that become loaded into the liver is what you need to remember. That's the reason increased serum iron, increased ferritin, increased transferrin saturation is equal to hemochromatosis is what you need to emphatically remember for the tomorrow's exam. Then what do you see in thalassemia? In thalassemia, RBC count become disproportionately high. So a patient came with a complete blood picture report, you found anemia, but the high RBC count is significantly high. Then you should think about thalassemia. Whereas iron deficiency, anemia, RBC count is low. Right? RBC count. There is a word, there is one of the parameters in CBP is RBC count. Then increased total RBC count in spite of very mild anemia characterizes the thalassemia is what you need to remember. So in thalassemia, what happens fundamentally, is the iron available in thalassemia? Iron. It is available. Only hemoglobin, globin chain production is affected genetically because of a mutation. So that is the reason hemoglobin is produced, but in smaller quantity. So RBCs are all of smaller size. So whenever you are producing smaller laddus, you have to produce more laddus. That is the funda behind high RBC count in thalassemia. Okay, so that's a point you need to differentiate. Now comes Menses Index. What is the meaning of it? Menses Index means, first of all, what is that index? What is the norm? How do you calculate that index? MCV by RBC. That is the count of RBC. How many RBC count is there? That is called Menses Index. So what is happening in iron deficiency anemia? MCV is decreased, RBC count also is decreased. Both of them are decreased. That's the reason denominator is decreased means value will increase 1/2 versus 1/4. Denominator is smaller means half is bigger than 1/4. No, today only I am teaching my 8th class mathematics to my son. By mistake, he did the problem wrong. -3/4 plus -2/8. I made him to do 100 problems of this type. Right? So, most important thing is we should know where we are falling short. Quickly fill those areas when you are going for entrance. A lot of times where students, in spite of hard work, why they don't get seat. If you do hard work, you will identify the right method. But we do half-baked hard work, it is called. So you will take one mock test of some fellows like us who offer a package. Then we will give a score predictor. To prove a donkey that it is donkey also is charged by our mobile apps. Am I donkey? Compared to last week, I am donkeyer. I am donkiest. So half your time is gone into worrying about why you are getting donkey, donkeyer, donkiest, most donkiest, very most donkiest. So don't worry about, but still you need to take mock tests because mock tests will bring that objectivity. Am I improving compared to last week to this week or not? But if you know where are you, what topics you are missing, quickly cement them. Automatically your scores will improve. Right? It's like taking clomiphene citrate leading to ovulation by next cycle. Hyperovulation and twin pregnancy. Both iron-ICET and NEETPG, both the things you should crack. So now, let's come to Menses Index. So, MC, beta, ye band karo, jara, bahar se wo aa rahe. So, MCV by RBC count. RBC count is typically increased in thalassemia. That's the reason the ratio become less than 13. So, Menses Index less than 13 is thalassemia, more than 13 is iron deficiency, and Menses Index is MCV divided by RBC count. That is what you have to emphatically remember. So MCV by RBC count will give you the Menses Index. Please don't forget. If the Menses Index is less than 13, then it is thalassemia. More than 13, it is iron deficiency. And in more than 13, iron deficiency, because denominator is low RBC count. So in iron deficiency, marrow cannot produce many RBCs. They're all small. Whereas thalassemia, there are small, but many RBCs are produced by the thalassemia. That's what you need to appreciate. The normal RDW is a feature of thalassemia. Right? Once more, thalassemia, there are varieties. How many varieties you have? Thalassemia minor, where it is a heterozygous condition. Thalassemia major, which is a homozygous condition. Very common. Thalassemias in our community are very common. Sickle cell anemias and all that. DM hematology people will do after doing MD. Thalassemia unit in the college. Good. Especially Kurnool and all these areas, tribals and all, they do a lot of Bava Mardi, Mama, Managodalu Pellilu. So that's a point. So thalassemia trait. So how do you differentiate thalassemia trait from major? RDW is, how is RDW? Red cell distribution width. If it is thalassemia minor, it is normal. But thalassemia major people, the RBCs will be broken within the bone marrow, even before launch. That's called ineffective erythropoiesis. And that intramarrow hemolysis will lead to more production. That lead to increased RDW if it is a thalassemia major. So iron deficiency anemia, thalassemia major, both lead to increased RDW, but thalassemia minor will lead to normal RDW is what you have to ultimately remember. So what conditions you see with a reduced MCV and a normal RDW? Now comes important, interesting question. RW normal, RW high, RW low. Red cell distribution width low. So high. So let's look into this important matrix, right? A lot of times examiner will try to play with you by here, there playing around. Normal RDW means what? Normal RDW means no anisocytosis. No anisocytosis. Increased RDW means anisocytosis is there. So iron deficiency may MCV is low and increased RDW. You all agree? Anemia of chronic inflammation, hypothyroidism. RDW is high, but normal MCV. Megaloblastic anemia, MCV is increased with the increased RDW. So in all these conditions, you have anisocytosis. In case of bone marrow aplasia, aplastic anemia, RDW is normal and MCV is increased. Beta thalassemia, MCV decreased, but RDW is normal if it is a thalassemia trait, heterozygous. All right. So this is what you need to remember. So what are the classical features of iron deficiency anemia? Number one, you have microcytosis, hypochromia, poikilocytosis, anisocytosis, and target cells. Target, like central increased opacity. We pass arrow, no? So it will go and hit the target. Target will have circles like this, no? Right? So target cells. Then thalassemia minor, you have elevated RBC count, whereas iron deficiency anemia, RBC count is reduced. Already we discussed this point. Then how about chronic renal failure? Chronic renal failure has normocytic normochromic anemia because erythropoietin is not produced. Bone marrow is still there. And there's a deficiency of erythropoietin in chronic renal failure. Now, what lead to iron deficiency due to blood loss? Fatapat, 8 causes you need to remember. 1, hemodialysis, PNH, then any bladder neoplasm, because they'll have hematuria is the common presenting feature. Any prosthetic heart valves where fragmentation of RBCs is there, frequent blood donations, hookworm infection, carcinoma colon, menstruation, very common cause for iron deficiency anemia. What lead to iron deficiency? Because of malabsorption of iron. If there is a echlorohydria, because you need an acidic pH for iron absorption. So everybody, what do they take? Pantacid. Right? So one of our very good friend, after 25 years, you all friends frequently catch up. Meeting for eating and drinking, that's the only thing that you will do beyond 25 years. So when we meet, especially surgeons drink like orthopedic surgeons and all in our class, they drink. Peg is understatement. Quarter is understatement. क्या रे quarter के बारे में बात करते हैं? मिनिमम हाफ या फुल निकालना है, तो खाली एक बॉटल आए तो क्या किसके लिए काम करेगा? ड्रिंक. So before drinking, he'll call the compounder guy. Hey, जाके एक पैन लाओ रे मेडिकल शॉप से. To take the pan and then start the whiskey. Earlier days, they used to have a soda and drink. So now Pantacid, and that's a style. So continuously when you are taking a Pantacid like drug, that lead to echlorohydria, and that lead to development of iron deficiency. Any atrophic gastritis, it can be autoimmune atrophy. What is meant by pernicious anemia? Pernicious anemia means the auto-antibodies going and destroying the parietal cells of the gut of the stomach. So only if it is autoimmune destruction, then only you call pernicious, right? So atrophic gastritis, any gastric resection or gastric bypass, any vagotomy you have done. Vagus stimulates acid. If there is no vagotomy, lead to echlorohydria, leading to iron deficiency. Any intestinal bypass, because duodenum, jejunum, they are all required for iron absorption from the gut. Any celiac disease involving the gut or tropical sprue. So these are the causes for iron deficiency because of malabsorption is what you need to remember. Increased iron requirements, where do you see lead to iron anemia? Pregnancy, lactation, growth, any erythropoietin therapy. If you are giving erythropoietin therapy, concomitantly you should also give iron. If you don't give only erythropoietin, then that once more worsens the iron deficiency. And when you are giving the erythropoietin, some of the patients will have suboptimal response to this recombinant human erythropoietin. So that's the reason whenever you are giving erythropoietin therapy, you should also be sure that whether iron supplementation is properly done or not in that patient who is having renal failure. So some of you down the line will become DM nephrology one day, and there are many nephrologists across the country who sat like you, attending the class in the past quarter century, almost 23 years, right? So, what are the conditions where increased absorption of iron occur? Remember that those who have iron deficiency, gut is very hungry to absorb iron. Little iron therapy you give also, it will be absorbed super fast. Similarly, any condition that lead to increased erythropoiesis, pregnancy also, they have a lot of ability to suck the iron. Hypoxic conditions, acid pH, increased animal food. Iron in the mutton is stronger than the iron that comes from pappu or vegetables, right? Be very sure. Then iron may you have ferrous ferric salt. Ferrous salt is more absorbed than ferric. So these are all the conditions that enhance the iron absorption. So where do you see opposite? Reduced absorption, alkaline pH, insoluble iron complexes, inflammatory disorders, right? And what lead to alkaline pH? Pancreas secretions are all alkaline, right? Any decreased heme iron, that is you are eating vegetable iron. So now what are the clinical signs and symptoms very specific for iron deficiency? Pagophagia, eating ice cubes from the refrigerator. It's a pica for ice. Pica means eating soil. Pica for ice is called pagophagia. Koilonychia, which is spoon-shaped this thing. Then blue sclerae. These three are considered to be highly specific for iron deficiency. Then glossitis. completely shaved tongue, angular stomatitis, post-cricoid esophageal web that can become malignant, gastric atrophy if you do endoscopy, restless leg syndrome. They are also the symptoms which you see in iron deficiency is what you need to remember. Now comes, what is Plummer-Vinson syndrome? What the triad? Iron deficiency, dysphagia because of esophageal web, atrophic glossitis, angular stomatitis. So this is the esophageal web. If you do endoscopy in the esophagus, you find a web. This is the web. Okay? So esophageal web leading to dysphagia, inability to swallow, atrophic glossitis, angular stomatitis, iron deficiency anemia. The combination is called Plummer-Vinson. What is the other name for Plummer-Vinson? Patterson-Brown-Kelly syndrome. Nausau-Chubey-Kaker, बिल्ली हंस चली, कभी सुना क्या? Nausau-Chubey Kaker, after eating 900 rats, mouse, the cat went to Huz, Makkah, to wash the sins. So last 30-day preparation, people ask, no, I will tell the same. Nausau-Chubey Kaker, अभी नीट पीजी नोटिफिकेशन आने के बाद बिल्ली चली, बिल्ली हंस चली, right? So now only you should wash all the dirt. Patterson, Brown, Kelly, Plummer-Vinson, they're predisposed to hypopharyngeal squamous cell carcinoma, and it's more common in women. It's a risk factor for post-cricoid hypopharyngeal carcinoma, right? So that's the reason I always tell the students, after the NEETPG, they'll be sitting in unnecessary. Depression is unnecessary. Why depression? You never cared to read, that's the reason you didn't know. You cared about something else. You cared about going on a bike ride on Royal Enfield, mountain biking, all those beautiful things that your testosterone permitted, right? So what? Now you sit. 6 महीने मेरे साथ बैठो, मैं तुझे वेदांती बनाऊंगा. I will take you to make you Shankaracharya if you sit with me for 6 months, right? In spite of 6 months, what is the situation, sir? They ask. 6 months we attended with you, sir. Every day you came, I came, we both sat and did meditation. Still seat nahi aaye to? I will commit suicide. Not you. Because 6 months of my life I wasted with such a stupid idiot who could not get the seat, even though I am shouting at the top of my hypopharyngeal cricoid area to push the concepts, right? So it doesn't happen, right? Now, it's like asking, if I marry you, will you produce pregnancy? Nobody can guarantee. But definitely, we can be sure to give you a pleasurable experience of marriage. So that way, squamocolumnar, what is Kaczynski's ring? Squamocolumnar or a lower esophageal ring is Kaczynski. Whereas post-cricoid web is what you see in Plummer-Vinson. A lot of times examiner will try to confuse, do you see Kaczynski in Patterson-Kelly-Brown syndrome? So if you don't know what is Kaczynski, if you don't know what is Patterson-Kelly, happy. You can still correctly answer. If you know either of them, you will definitely answer wrong because you feel I know something about it. Now, what is the best test to screen iron deficiency is a very important question. Serum ferritin. Decreased serum ferritin is the first most sensitive and specific test for iron deficiency. Anybody say, maybe this is iron deficiency, you send for iron studies. In that you check for ferritin. low ferritin, low iron, microcytosis, anemia, iron deficiency. That's how you control. So the level normal is 15 to 300 is the ferritin level. Please don't forget. Because you know all this, but you don't know what is the normal value also can make you die in the exam. So the level less than 15 indicate iron deficiency. Earliest recognizable morphological change in erythrocyte in iron deficiency. Favorite MCQ. Anisocytosis. That's the reason increased RDW is one of the very early whistleblower of iron deficiency. Then in iron deficiency, normocytic normochromic anemia with anisocytosis, first what you will see. First it will be normocytic, not microcytic, normocytic, normochromic and anisocytosis. Then they develop anisochromasia, hypochromia, then microcytosis. So anisocytosis followed by microcytosis followed by hypochromia. Always remember AMH. Anisocytosis first, microcytosis next, and hypochromia last. Losing the color of the hair, if hair is still there, is what you will do last, no? So remember, chrome is gone last. So first is anisocytosis. Now, what is the body iron content? Normal iron is, serum iron is how much? In a 80 kg man, sorry, not serum iron, total iron, 600 to 1000. Adult female is 0 to 300. Right? Then comes neutrophils, megaloblastic anemia. What is a classical finding in the complete blood picture that will say this patient is having megaloblastic anemia? Hypersegmented neutrophil. Hypersegmented neutrophil. Please don't forget one of the favorite question of the examiner. Hypersegmented neutrophil. Normally, neutrophil will not show this many lobes. These many lobes are there means it is megaloblastic anemia. More than 6 lobes defines a hypersegmented neutrophil. One of my professor's favorite question. One single cell of the hypersegmented neutrophil, there also it is megaloblastic anemia. One single cell is enough. Another thing, megaloblastic anemia patients, very common clinical finding. You look at their knuckles, hyperpigmented knuckles will be there. Right? So don't immediately jump. So hyperpigmented knuckles. Some teachers have a very characteristic things. Immediately as the patient comes, fellow, they used to look into this. There is hyperpigmented knuckle. Come on, get the vitamin. How often do you eat chicken? Said, no, I don't eat chicken. Finish. Diagnosis clinically only is hyperpigmented. Then they used to say, quickly send serum vitamin B12 folate and then start folvite in the OP only. Right? So a lot of times that turns out to be true. Next, how do you give iron? Common question asked by the patient. Tinnankara, tinakamundara, eppudu. It should be on empty stomach, oral iron. And food will inhibit the iron absorption. Then, if a chlorohydria is there, then patients will absorb iron poorly. If you give vitamin C along with concomitantly, then they will get benefited. Then, how much iron you need to give when you are started oral therapy? Idea is to give 200 milligram of elemental iron to the adults. So 200 milligram of elemental iron, if you give, then it will lead to an absorption of 50 milligram per day. Right? So during our time, do you know how much is the stipend in Kakatiya Government Medical College? 1,800 rupees. So first time I put a finger on the signed on the revenue stamp is when receiving the stipend in as an intern. So after signing, he gave 1,600. I asked, where is the 200? Jao sir, chahiye nahi chahiye, jao. So 100 house surgeons into 200 rupees, 20,000 rupees every month is his personal money, right? So like that, if you give 200, only 50 will go into the body. Then you should give ferrous iron salt, oral iron therapy. You should begin with that. Ferrous preparations are best absorbed and least expensive. Ferrous, not ferric. Ferrous fumarate. So ferrous sulfate, 325 milligrams, 3 times daily. Most commonly used oral preparation, right? So after studying MBBS, if these are minimum things, we should be able to write to our own maid in the home. To her also, you can't write iron therapy means, huh? Or your maid is pregnant and you don't know how to give her a TT injection, it's not worth doing MBBS. So 325 mg tablet of this ferrous sulfate contains 60 to 70 mg of iron. So that is the reason you will be giving it 3 times daily, right? So what a anarchy. 325 mg, how much will be available? 65 mg. 3 times you give means you are giving 200 mg. Out of that 200 mg, only 50 mg will come to the body, is what you need to remember. All right, doctor? So don't forget this. Even in preventive medicine also, this is one of the favorite question. So after you give iron therapy, when will retic count will improve? Retic count should begin to increase 4 to 7 days after starting the therapy. It will peak in 1 to 1.5 weeks is what you need to remember. And another important thing, once you started iron therapy, initially absorption is high. Because anemic person has a high erythropoietin and that will make all the iron that you give initially high. The moment anemia is getting corrected, erythropoietin levels will decrease and your iron absorption also will not be as good as what you have given first. First time when you give 50 mg zup, it will suck out of whatever that you have given. If you give 325 mg thrice daily, out of 200 mg that elemental iron gone, 50 mg get absorbed initially, but not later. So the goal of therapy with iron deficiency is not just to repair the anemia, but also to provide stores. How much stores? At least 0.5 to 1 gram of iron. So that is, in order to provide this store, you need to supplement for 6 to 12 months for correction of anemia. So a lot of common mistake done by the people is, like antibiotics, they give it for 10 days. Right. So don't do that. At least 6 to 12 months, patient should be advised to take the iron preparation. And when will hemoglobin will start getting corrected, fully corrected within 1 month of initiating therapy, if there is no ongoing blood loss. That's the reason always you will ask the patient to come back and check the hemoglobin in spite of giving supplementation. If the iron is anemia is not improving, should look for occult loss of blood or heavy menses. All this history you need to take. Now comes, when will you give parenteral iron supplementation, right? Either by injection or by infusion. If the patient can't tolerate iron therapy, poor compliance with the iron malabsorption, persistent GIT loss, unresponsive to oral therapy, and similarly, if the patient is on erythropoietin therapy also, you need to give parenteral. Then patients on erythropoietin and hemodialysis. Similarly, patients on erythropoietin for anemia of chronic disease. In all these patients, parenteral iron is indicated, is what you need to remember. So most of the times, the parenteral iron which is required is given as intravenous infusion, IV infusion. So how many forms of parenteral iron are marketed? Iron dextran is most common. Sodium ferric gluconate in sucrose. Sodium ferric gluconate in sucrose. Then iron sucrose. Then ferrumoxytol. So this is ferrumoxytol injection. Other is iron dextran. This is most common. This is also used. Ferrumoxytol. Right? Even what you call iron sucrose, iron sodium ferric gluconate are also very much in usage. There are newer non-dextran formulations. Dextran is more slow to get absorbed. Non-dextran, more elemental iron per dose is delivered. If you want a rapid correction of the iron deficiency and you want to improve the compliance, is what you need to remember. Another thing is dextran iron has more adverse effects compared to non-dextran formulations. And of all this, for which iron preparation do you need to do a test dose to look for anaphylaxis? Very commonly, iron dextran is the only formulation that need a test dose pre-medication before you administer. Non-dextran formulations, no problem, right? Now, in which conditions you see iron overload state, right? Thalassemia. Even though it leads to microcytic hypochromic anemia, it predisposes to iron overload. Citroblastic anemia. Any chronic hemolytic anemia also. Suppose if hemolysis is occurring within the body, all that released iron will go and deposit in the liver. Similarly, any transfusional iron overload, parenteral iron overload, that is what you need to basically remember. Then iron overload states also include chronic liver disease, hepatitis C, alcoholic cirrhosis which is advanced, alcoholic steatohepatosis, then porphyria cutaneous tarda, hereditary hemochromatosis, dietary iron overload, portocaval shunting, right? Those who are having portal hypertension, you will be doing portocaval shunting. IVC and portal vein are being shunted. So these are all the causes of iron overload. One list is ready for you, doctor. Be very sure about it, right? Right. So now let's talk about anemia of chronic disease. In this, what happens? There is a block of delivery of iron from the reticuloendothelium cells system that is in the bone marrow to erythroid progenitus. Because of that, patient has an increased iron store in the marrow, increased ferritin levels, but because there is a block in the delivery of the iron, the serum iron level will fall and TIBC, total iron binding capacity, will fall and transference saturation fall. But in iron deficiency, serum iron is low, TIBC is high. Whereas in thalassemia, in anemia of chronic disease, serum iron is low, TIBC is also low. That's the differentiator between the two. All right. So one is ferritin high, thalassemia. anemia of chronic inflammation. Ferritin low, iron deficiency. TIBC high in iron deficiency. TIBC low in anemia of chronic disease. That's what you need to ultimately remember. Every entrance you go, doctor, how do you differentiate iron deficiency from thalassemia, from Citroblastic Anemia, from anemia of chronic disease? Invariably, one question nahi hai to mera zimmedar. Right? Definitely, they will ask in every exam. Right? Logically, you need to remember, no confusion exam mein. Is it TIBC high, TIBC low, TIBC high, TIBC low? No confusion. Clear cut. You need to be sure why TIBC is high, why TIBC is low, why ferritin is high, why ferritin is low here in IDA. Right? You need to be sure. Now, what is TIBC? Total iron binding capacity. The sum of all unfilled iron binding sites on the transferrin. So transferrin carries iron, ferritin stores iron. So this transferrin, which is carrying iron, has iron binding sites. The total number of unfilled iron binding sites on transferrin is called total iron binding. Obviously, more the unfilled iron binding sites, it can bind more, right? So it is the total quantity of the iron that saturate all the iron binding sites of transferrin after the addition of exogenous iron to the serum is TIBC. If you add iron, how much will be sucked by your transferrin is total iron binding capacity. So obviously, total iron binding capacity depends on what? Concentration of transferrin in the serum. And what happens in the people who are having anemia of chronic inflammation? Their transferrin levels are suppressed. Ferritin levels are increased. So because of that, the whole TIBC will become decreased. Whereas in iron deficiency anemia, transferrin is normal, but the iron unfilled sites are more, hence TIBC is increased. Barabar? Abhi samajh mein aa gaya? Very good, very good, very good. So, doctor, transferrin saturation, how do you calculate? It is the serum iron concentration by total iron binding capacity is called saturation. All right. So transferrin saturation is serum iron by TIBC. That's the reason what happens in iron deficiency anemia? Serum iron is decreased, TIBC is increased. So numerator decreased, denominator decreased means what happens to the value? Decreases. That's what you need to remember. All right. So where do you have hypochromic microcytic anemia with a decreased serum, increased TIBC? Iron deficiency. Microcytic hypochromic anemia with decreased serum iron, decreased TIBC? Anemia of chronic disease is what you need to remember. So TIBC is typically decreased in anemia of chronic disease, typically increased in iron deficiency, whereas transferrin saturation is decreased in both transferrin saturation, percentage saturation, decreased in both anemia of chronic disease and also iron deficiency. So please don't forget 50 to 160 microgram per deciliter is serum iron, 250 to 450 microgram per deciliter is TIBC, and 20 to 55% is transferrin saturation is what you have to ultimately remember. So what do you see in chronic renal failure? Normocytic, normochromic, hypo, proliferative anemia. Anemia of chronic renal failure? Always remember in a patient of CRF, the more severe the anemia, the more is the severity of renal failure. Because everybody is CRF. Within them, if you do the glomerular filtration rate calculation, somebody has less than 20%, somebody has 20 to 30%, all of them are CRF only. So the more severe the CRF, the more severe is the anemia, is what you need to remember. And what are the cause in CRF because of the decreased erythropoietin production? So CRF patients who are having anemia, how do they present? They have normal serum iron. CRF patients. In CRF, there is no erythropoietin. That's the only problem of them. But their serum iron, TIBC, ferritin levels, all of them are normal. In case of CRF, is what you need to remember. And erythropoietin is the mainstay of treatment that you can help a patient of CRF. But if you are giving patient erythropoietin, you should be sure to also supplement iron. That's very important, right? Now, a CRF patient, just because you did dialysis, will it improve the ability of a failed kidney to produce more erythropoietin? No. Dialysis is only draining out your uremia. So that is the reason dialysis does not improve the anemia of CRF. This is another favorite question. What clinical manifestations of CRF are dialysis improvable? Not improvable. The list in the 20 out of 20 features, what are improvable, what are not improvable list is there. Will come when we discuss CRF, don't worry. But that's a favorite question of examiner. But remember, dialysis has no effect in correcting the anemia in anemia of chronic renal failure, is what you need to remember. But there are two types of dialysis: peritoneal dialysis versus hemodialysis. In hemodialysis, directly blood to blood exchange. So there is a great chance of losing blood. In fact, hemodialysis can promote iron deficiency anemia. Whereas peritoneal dialysis that we do, ambulatory, that improve anemia. But neither of them will reverse the ability of the kidney to produce erythropoietin. That's a point you need to appreciate, is what you need to understand. So good, doctor. 1.5 hour batting we finished. 1.5 hour batting. Already what's the time? 8 o'clock. Nowadays, even my gut clock is also scheduled to your hostel time. You still have energy? No. Huh? Yeah. So almost 1.5 hour we had. So tomorrow we'll try to start surely a little early, 5 o'clock. And as we progress, we will have morning sessions also. Thank you very much.